Our next speaker will be Dr. Kalyanam Shivkumar, who is the director of the UCLA Arrhythmia program. Those of us at UCLA like to take credit for his training, but I have to confess that Dr. Shivkumar has traveled pretty much throughout the world, but mostly Europe and Australia, trying to bring the latest techniques for arrhythmia ablation to UCLA. And he'll be talking about some of those techniques in his talk about ventricular arrhythmias.
Well, this is one of the high points of UCLA CME programs because I have an opportunity to make a presentation with two of my teachers chairing the session. So I was asked by Jamil and our team, Kevin Shannon and Jeremy, to address ventricular arrhythmias, which of course is a topic of great interest to the UCLA Cardiac Arrhythmia Center. So along the lines of the program that Dr. Child and Dr. Perloff had set up here at UCLA, we started this journey over a decade ago, and these are my acknowledgement slides, and of course I'd like to thank the American Heart Association and the NIH. Although these are bad times, we still are able to get funding for some of the research that you'll be seeing in this presentation. So the mission of our program, analogous to what the Ahmanson UCLA adult congenital program at UCLA has, is to generate new knowledge in the field of cardiac electrophysiology and cardiovascular therapeutics. So we add this as a part of our mission, which will be hopefully evident during this talk. And of course, we've had the unique opportunity to work with some of the brightest pediatric cardiologists in the world, and also to work with some of the best transplant doctors and surgeons in this planet. And there's not a single day that goes by when we discuss a case with Kevin or Jeremy or Ravi that we don't leave that conversation having gained a few IQ points. So what are the electrophysiologic goals in adult congenital heart disease, and what is relevant to ventricular arrhythmias? The mission here is, of course, preventing sudden death. We have a big role to play in heart failure. Implanted leads management is a big issue in our field. Ventricular arrhythmias sort of links some of these reasons. In fact, it's to prevent ventricular arrhythmias that we create some of these technologies to prevent sudden death. And I'll be talking a little bit about how there are new things for biological therapy, cardiomyopathy management, and also neuromodulation, which is a very exciting new area that electrophysiology is paving the way toward. So we have clinical programs, educational programs, and programs of science and innovation. And we think the management of patients with congenital heart disease is extremely special to us because there are very few programs in the world or electrophysiology programs that have access to such a phenomenal, well-established pediatric and an adult congenital program. And so we consider this to be sort of the jewel in our crown, and you'll see why. One of the fortunate things that happened at UCLA was the ability of the pediatric program at UCLA to make this link with Loma Linda, and we were able to join forces with Loma Linda and bring Ravi to UCLA to join forces with us. So we have two medical schools that interface closely with us. This slide sort of sets the stage for the main topic of discussion, and that is, this comes from a citation classic, and I usually give this to general cardiology fellows who are not going to go into adult congenital heart disease to read before they sit for their boards. And this is John Treidman's beautiful write-up, and it pretty much in one slide gives you what is established knowledge in the field. And I'll just focus on the areas that I've underlined. Arrhythmias are a significant cause of morbidity and mortality in this group of patients, especially in the later decades of follow-up. So when you read Dr. Perloff's textbook, Perloff, Child, Abulhossen's textbook, one of the big concerns is long-term survival, and how do we make sure that the miracles of the early part of your life don't end in tragedies as you live longer. So we heard from Jeremy and Ravi about atrial tachycardias, and of course, the theme of this year's symposium is interventional strategies, and let's talk about interventional strategies for ventricular arrhythmias. So to understand strategies, you have to at least have some framework of pathophysiology. So what are the key aspects of pathophysiology? This is a slide that many years ago, Dr. Child lent this to me, and of course, to maintain a retro feel, I made sure that we took a 35mm lantern slide and converted it into a digital version. And of course, in science, generally to solve one set of problems, maybe to create a whole new set, and of no science is this more true than of medicine. Which is true, that's, when you look at it, the surgical scars or any interventions that is performed to fix a mechanical problem leaves behind a footprint, an electrophysiologic substrate that sets the stage for future problems. And indeed, in the heart, this happens in adult heart disease when you have a myocardial infarction. When you have an electrical scar, this is a patient who underwent ablation, subsequently had a heart transplant, and Dr. Fishbein made the slide for us. And what you see over here is a myocardial scar that is stretched, and this is the substrate for slow electrical conduction that is responsible for ventricular arrhythmias. Now, understanding scar biology is very central to understanding ventricular arrhythmias. And the line of reasoning is as follows. Here's an image of a heart, a CT scan, on which we have superimposed an electrical map. So what is blue here is viable muscle. What is gray in this particular image is a myocardial scar that is defined by electrical signals. So when you have these scars, what we have learned in the past 2 decades is deep within the scar, there are still small strands of muscle that is still alive. And I see many of our CCU nurses here, and they are the world experts in handling this. So when you have ventricular tachycardia, this is electrical impulses going around these strands of muscle that is alive deep within a scar. Now, as it turns out, we've also learned that when scar merges into normal myocardium, you can also get PVCs that can result in VTVF. And the joy of knowing this is the fact that we can actually use a catheter, get close to some of these electrical circuits, and fix the problem. So the substrate is more complex. So in addition to what happens with a scar, there are also functional changes. And here's a little cartoon of an action potential showing you that there are significant changes in the action potential of the heart. So 2 things are acting in concert, scar and the functional regulation of the scar that sets the stage for the perfect storm, which is arrhythmias and sudden death. So what is the big picture? It goes something like this. Scars give rise to ventricular arrhythmias. Sometimes, as in several congenital diseases such as long QT syndromes, you actually do not have a scar, but you have the electrical arrhythmic substrate, which is completely functional, which can result in sudden death. And we have now learned that all of this is very powerfully regulated by the nerves that go to the heart. And fortunately, we are able to do something about it. And there are diseases, and I'll briefly allude to this in this presentation, where we can actually cut the nerves that go to the heart, and that can also prevent ventricular arrhythmias. So this is the framework. So how do you apply this knowledge to real-world medicine? This is where it gets interesting. In the past decade, there's been a huge revolution in imaging and in interventional therapies. Here's a MR image, and in this conference, you have some of our imaging experts who will be talking, where scars in the heart can actually be seen non-invasively. Here's an MRI image showing myocardial scars. We can also look at scars by placing a catheter in the heart and moving it around and trying to register the amplitude of electrograms that we measure. And here's an example of a patient with a tetralogy of Fallot, where you can actually identify myocardial scars on this computer map. So you can see it using catheters, you can actually measure it. And as it turns out, many years ago, Dr. Perloff, when I was a general fellow, made Nicola Tede and myself to sit and work on this paper using signal average ECGs. And a signal average ECG can pick up late potentials, which is the electrocardiographic marker or a footprint of scar in a patient's heart. As it turns out, if you have a scar, you can actually go test it. Here's data from Boston Children's, where Dr. Mandapati trained, and this is a data set where they took patients who had TOF and performed electrophysiologic studies in them, and this is useful data. So you can actually perform an electrophysiologic test and try to prognosticate, try to find out what is the risk of arrhythmias in its given patient, and develop strategies for preventing sudden death. So You can see scars, you can measure scars, you can test scars. So there is a framework that emerges from the studies in the past decade. Adult congenital cardiologists and certainly pediatric cardiologists spend a substantial amount of their time dealing with children who've had very serious congenital abnormalities, who've undergone surgical procedures, and post-surgical ventricular arrhythmias is by far the biggest group of patients that typically adult congenital and pediatric cardiologists worry about and tackle. And as I told you, the fact that we now have an interventional therapy has improved treatment. I wouldn't be the expert in our extended group to be talking to this. This is really something that Kevin, Jeremy, and Ravi can address better. But I'll show you an example of a case, and I like this particular case because this is over a decade ago. But this is a case that in a very small lab in the old UCLA Medical Center, Kevin, Shannon, and I struggled through. So TOF, as many of the experts in this audience know, and some of our nurses have taken care of these patients, sets the stage for various electrical circuits in the heart that can give rise to ventricular tachycardia. And usually these relate to areas where the VSD patch is sewn in, and also areas between the outflow tract and the ventricular musculature. Now, here's a quick illustrative case. A 14-year-old kid with TOF had a complete repair, presented with a sustained white complex tachycardia. There were 2 VTs that were mapped to VSD margins. So we decided, of course, this kid also had significant pulmonic regurg, was referred for surgery. And we recommended at that time that the surgeon try to perform a cryoablation, and they did make an attempt. However, the patient postoperatively presented with the same white complex tachycardia, which is shown on this panel and in this panel, which, of course, to electrophysiologists, when you see this type of a pattern, it tells you that it's quite likely that the origin of this particular VT could very much be in a circuit that is physically in the same location of the heart. So what was done was, post surgery, the patient was brought back to the lab. And in the lab, we spent several hours mapping these 2 VTs, and we were able to map out the conduction system of the heart. So the reason why the surgeon did not tackle some parts of this VT circuit was the fear that it may result in complete heart block. And sure enough, it would have done that. And this is one of those situations where catheter ablation was able to sort of fix something that surgery could not fix. And this particular VT was successfully ablated. But the patient did have inducible polymorphic tachycardia for which an ICD was implanted. So again, one example, and there are numerous examples of this that our congenital team has done, and they have perhaps one of the largest experiences in the world in dealing with these types of arrhythmias. I'm going to spend a couple of minutes addressing a problem that many of you will encounter, but they are firmly in the realm of adult congenital heart disease, because these are diseases that can present in both childhood and in young adults. And that is, I thought I can talk a slide or two about Erythrogenic RB cardiomyopathy and Hypertrophic Cardiomyopathy. Here's a condition where catheter ablation has had a remarkable positive effect, and it's revolutionized the management of this particular condition. Erythrogenic RB cardiomyopathy is a serious disease. It can result in sudden death, and as it turns out, it has a substrate that can be effectively tackled by catheter ablation. So this is the quick view for the cardiology fellows. It's a disease that's characterized by RB enlargement. There's the so-called triangle of dysplasia that was described several years ago, deals with areas where there is fatty infiltration of the myocardium. And again, this is histology, this is the signal average ECG, this is an extreme case where you can actually see an epsilon wave. So what has been a big revolution in this particular field is the ability to map the heart from the outside. This is a technique that was developed in Brazil, and in the past decade, this is a review that's coming out next week in the journal Circulation, where we had a decade's review of this entire field. And Epicardial mapping, where we actually thread catheters on the outside of the heart, has allowed us to tackle very difficult arrhythmias that could not be ablated from the inside. So this is used all the way from accessory pathways that have failed to ventricular tachycardias. And the way the procedure itself is done is by placing a catheter in the pericardial space, which is done by using an epidural needle as shown in the slide. And once you have access to that space, you can create electrical maps. Here's data that Jason Bradfield, one of our assistant professors, has put together where you can actually combine multiple imaging modalities. Here's an example of fusing electroanatomic maps, as I described before, with CT scans, and you can actually see needles on the electrical map, and this is something which pediatric cardiologists, electrophysiologists have specialized in, and something that we adapted to adult cardiology, adult congenital use. And this is a data from a multi-center study that shows that arrhythmogenic cardiomyopathy is one of those conditions where epicardial mapping has had a big positive impact. And we were a part of a large multi-center effort where we actually showed that this type of an ablation resulted in very good long-term outcomes in patients with arrhythmogenic cardiomyopathy. What about hypertrophic cardiomyopathy? This is another condition where catheter ablation has had a very positive effect. And in the past decade, we have used many of these techniques to deal with complex substrates. Here's a paradigm that we developed. These are two colleagues of mine, Dr. Tung and Dr. Bush, who all were instrumental in a series of studies that were done by our team at UCLA. And we've come up with the big picture of how some of these complex arrhythmias are tackled. So what do you do in patients who've had prior surgery with complex substrates? It's worth highlighting in one slide that UCLA has one of the largest hybrid ablation programs for VT, where we surgically open the patient's chest in the electrophysiology lab for catheter ablation. And this is our initial experience that was published, and this is a little slide that I put together to highlight the fact that one of the organizers of the symposium, Dr. Ahmanson, has added skills as shown in this particular slide. He also moonlights as an illustrator for us. So we periodically commission figures that Dr. Ahmanson creates for us. And these are fairly heroic procedures, but they've resulted in very good patient outcomes. As shown in this slide, this is a patient who has a complex arrhythmia that originated from the base of a heart in a patient who already has an LVAD with dilated cardiomyopathy, had a valvular cardiomyopathy, which was due to mitral and aortic myxomatous valve disease originally. But again, this is one of those settings where you can actually go those extra steps to provide adequate control of an arrhythmia. Here is one of the few labs where you'd actually see surgical instruments in the electrophysiology image field. And I'll conclude by saying that there's a whole group of diseases that is not a topic of this presentation, but diseases such as channelopathies are very effectively managed by procedures that is well in the realm of EP management. And that's the whole field of neuromodulation, which is shown in this figure. This is one of these iconic medical images. And it brings up the big field of neuraxial modulation, which was typically used for channelopathies in children. And this has been a big focus of research here at UCLA. These are my colleagues, Dr. Vasegi, Ajijola, and Dr. Mahajan, where we've come up with ways in which we can control the sympathetic nerve output to the heart. And this has resulted in ways of stabilizing patients who have serious ventricular arrhythmias. So I'll conclude by saying that in the future, things that are going to be hopefully discussed in future conferences, you can call your electrophysiologists for ablating hypertrophic cardiomyopathy septum. Here's a case here done at UCLA where catheters were used to perform catheter-based septal myectomy by applying RF energy. And sure enough, this resulted in a reduction in the gradient, a subtle change in the QRS over here, and this patient at 6 months of follow-up is doing incredibly well with a sustained reduction in the gradient. We also have started doing this procedure where we do microcoils into coronary arteries for ablating ventricular tachycardia from the septum. The same approach can be used for hypertrophic cardiomyopathy. And last but not the least, the grand final slide. This is data that we are very excited about, which one of our colleagues who works on stem cells, Dr. Ali Nasser. These are the payload specialists, as we refer to it in our field. They make the satellites. The electrophysiologists are the people who have to actually get it to the heart. So all this knowledge on imaging and mapping is going to result in better therapies. So I'll stop with that, thank all my colleagues at UCLA, and thank the organizers of the conference for this invitation. Thank you so much.